Clinical medicine is fascinating and it's interesting, but if you've been doing it in isolation for a long period of time, you can get burnt out. It can have some negative impact. So for me, part of it was thinking, right, what can I get interested in, and how can I diversify my options in my career that will keep me interested. And research is a fascinating field, and particularly research that blends clinically applicable things with either new treatments or new pathways or just better disease understanding.
Hi everyone, so today's guest is going to be Dr Peter Rimmer, who is a gastroenterology registrar here at the Queen Elizabeth Hospital. So today we thought we'd speak to you and get a little bit of insight about your journey. And so would you like to introduce yourself?
Yep, so my name's Peter Rimmer, I'm a gastroenterology trainee, so I've been doing my research towards an MD for the last 2 years and in my penultimate year of training. So been sort of working as a doctor since 2012, working in gastroenterology since 2017, so it's been it feels like a relatively long journey at this point, but an enjoyable one nonetheless.
Good. So Dr. Rimmer is actually doing an MD, as he said, and this is a particular interest of mine because a lot of clinicians do tend to take time to do like MDs, PhDs. So can you tell us a little bit about how you got into that?
Yeah, so I think when you are undertaking gastroenterology training or any training, you start to envisage, right, where do you see yourself in 10 to 15 years and what is it about your job that's going to make you keep coming back? And clinical medicine is fascinating and it's interesting, but if you've been doing it in isolation for a long period of time, you can get burnt out. It can have some negative impact. So for me, part of it was thinking, right, what can I get interested in, and how can I diversify my options in my career that will keep me interested. And research is a fascinating field, and particularly research that blends clinically applicable things with either new treatments or new pathways or just better disease understanding. So that was a point of interest anyway. And then working in a centre like UHB, which is what I was doing at the time, you hear about projects, there's links with the university, you get these opportunities, and it was about being in the right place and being offered the project that I want, that appealed, and then taking that option. And there are processes that you go through within your training program to get approval for that, and they have to believe it's a project of merit and all of these different things. And once you've got those necessary approvals, then you can step out of your training to take some time to work towards this, which is what I've been doing.
Lovely. And in terms of like the projects, do you get like a variation between like lab-based or clinical?
Yeah.
And how much influence do you have in terms of choosing?
So this at the moment, going out program to do research or anything of that nature is very much an optional thing. It used to be, and this is a kind of testament to how things are within training at the moment, it used to be that really if you wanted a job in a big centre, you had to have an MD or a PhD. Whereas now it's gone from, to give you an example, my father-in-law applied for a gastroenterology consultant job in a small hospital. He was interviewing against 10 other consultants, all of whom had PhDs and MDs. Whereas if I were to apply to that same hospital now, I would be the only person being interviewed. So that is a point of relevance. So you have to want to do it, because you don't need to. And I think what you will find in terms of the project is it should be very much what you want to do. So because there's no obligation, you'll find opportunities either within the deanery being advertised or with people that you work with. It can be lab-based, it can be purely lab-based if you so wish. It can be purely clinical, so some people do it with based around endoscopy, doing advanced endoscopy or setting up new treatment pathways, and then some people do a combination of two, where you're bringing together clinical work that you're doing with the additional research project that you're doing alongside it, and that's what I've been doing. There are other things you can do when you're out of program, so you don't necessarily have to work towards an MD, but you have to be able to justify the merits of it as a sort of valued use of your time and a valued reason to step away from training.
Okay, I understand. And so what would the typical week look like for you in terms of doing a bit of clinical and a bit of research?
Yeah, so my weeks there's a lot of clinical work. So the role that I deliver at the UHB at the minute, or at least for the QE site, is I see all of the patients with suspected inflammatory bowel disease. So anyone referred with suspected IBD I see in clinic. I then arrange for their colonoscopy, which I then perform myself, and we're then following up the patients in their early disease course. So I'm doing clinics on a Monday morning and a Wednesday morning, sometimes a Thursday morning as well, and I'm doing endoscopy lists on a Wednesday afternoon and potentially on a Tuesday as kind of like an overflow thing. So it's 5 or 6 clinical sessions a week. And then within that, we're taking samples from these patients, or those of whom are interested in participating in research. We're taking additional symptoms that then I'm processing in that remaining time to try and kind of answer some of the questions that we're interested in. So that involves taking serum, and we've been running ELISAs on serum, taking stool samples, and trying to extract microbial DNA so we can get a bit of an idea of what's going on with the microbiome, using a number of different techniques. And then also taking mucosal biopsies that we're sequencing. So I'm not doing all of the components of that myself. It's part of a group, but I'm sort of predominantly getting the samples, and I've been doing all of the microbiome work and the ELISAs. The mucosal biopsies are slightly more complicated than some colleagues that have.
Yes. Oh, I can imagine. Well, it sounds like fascinating stuff. I mean, just the blood-based component of it, as well as being able to do clinically.
Yeah, I think it's a great opportunity to really get to grips with the disease that you're managing for a start, but also to understand how you can integrate clinical care with really good research, and also how research can improve clinical care. So, everyone will have seen various things about situations in different trusts all over the country at the moment via this pathway, which is established partially out of clinical need, but delivered because I'm at a programme doing research, has been able to markedly reduce the waiting time associated with kind of outpatient review, outpatient endoscopy, at a time where there's real strain. So we're getting people through the system quickly because this clinic exists. That's a big service improvement thing, which is also particularly for junior doctors or people who are coming through, find there's a real emphasis on service improvement and how we can make systems better for patients, and this kind of brings that in as well.
Absolutely. Okay, Dr. Rachel, so this is a bit of a point of interest in mine, and I'm sure a lot of people watching might be curious. Can you tell us a little bit about your own journey, like what made you go to medicine, why gastroenterology?
Yeah, absolutely. So I think for me, it started, it was kind of a funny course. So I always wanted to be involved with sort of, I had a very strong interest in human biology, that sort of stuff when I was in school, and that was my main interest, but I was also very interested in sports. So it started with maybe I could be a physio, and I was like, maybe I could be, you see the sports physios running on, and I was like, that looks fantastic. And I wasn't at a school that necessarily pushed you that hard academically. I was just at a kind of state comprehensive school, and I found that when I was looking at places to go, and when I was getting what I was predicted and then what I achieved, it became clear that actually I could do more if I so wanted, and it came down to how am I going to be able to have the biggest impact on helping people. And when I was going through the process of applying it, also, that sports physio thing was, it was a bit of a pipe dream. And when I sort of spoke to physios that did that work, a lot of them, if they did any extra sports stuff, it was purely voluntary, and it didn't look like a long-term option. And I felt there was probably, one, academically I was able, and two, there was a lot more that I'd be able to achieve in medicine. So that was what pushed me in that direction. I never regretted it. The job is at times difficult, of course, but I've always been happy with that choice. And then through my training, so initially I had an interest in surgery when I was a medical student, but through various placements, kind of got slightly pushed away from that. I wanted to be a bit more holistic. I wanted to have a bit more time for my patients. And there are specialties within medicine that give you that balance. So I'm not suggesting that gastroenterology is surgical, but you're dealing with complicated medical problems, but you also have endoscopic procedures that you're performing on a regular basis that kind of have that balance between the two. And when I first started doing my core medical training, I looked at lots of different specialties, and I was very interested in oncology because I liked the interactions and the support that you could give to patients. But I also felt that I needed something as part of my training that was a skill. I wanted, and there's huge skills with oncology, of course. Yeah. But yes, exactly. So a procedure that you performed, that you could develop, and that you could kind of improve your abilities in. And there are other medical specialties that bring that. So cardiology and respiratory medicine as examples, but gastroenterology was always the one that kind of appealed the most. It's one of my better choices in life as choosing gastroenterology. I've been very happy with my experiences in that. And so it comes down to keeping an open mind and also seeing where you will end up, because your experiences as a foundation doctor on a ward in a specialty will not reflect what your experiences will be as a consultant. Because you will be seeing similar types of patient, of course, but you'll be seeing those at the extreme end of the spectrum. You'll be dealing with sick medical patients, in gastroenterology, or if you're dealing with hepatology alongside it. But you're not seeing the endoscopy, you're not seeing the outpatient work, you're not seeing the well patients with chronic conditions like inflammatory bowel disease that you can keep in the community and really work for many years to look after. So I think often people are put off by medical specialties, and people are put off by core training, or IMT as it is now, because you have to provide more of that service and more of the acute medicine. But there is still a very good job at the end of it, and it's about being able to see through that and see that in the longer term there's something that's worthwhile going through that for.
Oh, that's brilliant. And yeah, I think it's always like great to see like some of my senior colleagues who've sort of just sometimes accidentally, sometimes like very purposefully like got to the area that they're very passionate about.
For me, the decision for gastroenterology came as a CT2, so in my 4th postgraduate year, and in order to kind of get things right, to make sure when I applied, I did a fellow year between my CT2 and my ST3. So my final year of core training, my first year as registrar, I was an education fellow in a different trust, and I had a day a week for gastroenterology. So I got to start scoping and did some capsule endoscopy, and I did some clinics before I took a job. One, because then I was sure that I liked scoping, because I thought if I get an ST3 gastroenterology, I pick up the scope the first time and I hate it, then that's not a great situation. So, and it gave me time to improve my application as well. So I think if you're not sure, there, trusts are always on the lookout for more people, and in order to do so, because every trust is in the same position, you can argue for a more competitive job that gives you what you need. You don't have to just take what's given. And so if you're not sure, or you want to experience a bit more, you can do something like that. I've got a postgraduate certificate out of it, I've got additional clinical experience, and there are different things you can do that will enhance your application whilst making sure that you're doing the thing that you will enjoy long term.
Well, actually, you started answering my next question, which was that obviously in medicine there's a lot of decisions that we have to make in terms of specialty. Do I take time out training? Do I make research? So I know you touched on some of it already about like try and get experience and stuff. But do you have any advice for young trainees like myself or anybody else watching in terms of, when you're kind of at those like crossroads, how do you make the decisions? How do you know what's good for you in terms of like life and family and like just career in general? Yeah, and I think life and family are big questions, aren't they? Because you find obviously there's huge amounts of pressure and negativity within the NHS at the moment. So you do have to weigh that, and lots of people are kind of going other places to do their work. And I think for me, big proximity to family is one of the things that prevented that, and will do for lots of people. And I think I guess the most helpful thing I would say is that there is no rush, and that I've been working since 2012, and I'm 33, and I'll be a consultant when I'm 35, and then you're expected to work another 30, 35 years, right? So you've got a very long time to be a consultant at the end of this, and you want to be in a position when you reach the consultant level, or whatever it might be, that one, it's what you want to do, and two, you've done enough on your route there to be able to get the job that you want, and not just the job that's available, because you've got a very long time to be a consultant. So if you aren't sure about your specialty, or if you aren't sure about kind of where you want to be, take some time, do an extra year here or there, go even if you want to do a year somewhere else, do it, because you've got a very long time at the end of it to be at that consultant level. And there's often this kind of conveyor belt, and this the way health education is set up and the way training programs are set up, it wants to push people through, and they've made that even harder now. So for gastroenterology trainees who have done IMT, they come in at ST4, they've got ST4 to ST7 to learn how to do OGDs and colonoscopy, which was hard enough as it is. So everyone gets this tunnel vision on this is what I must achieve at the end of it, but then you come out, you've just about managed to do colonoscopy so enough, you can't do any of the other stuff, you haven't got any advanced skills, you haven't done any research, etc. You shouldn't feel pushed, and I think it's important to try and take the time to make these decisions. So whether that's doing research, whether that's doing additional placements, whether it's going abroad for a year and doing fellowships, take the time and explore it. And if you try it and you don't like it, well, at least you know, and you've not committed yourself to a long-term consultant post in something you then don't like, or in a job that's not how you would want it to be. No, that's completely understandable. And so the next question is something that I like to ask everybody who comes in, and that's like, can you share with us a highlight in your career journey, and then followed by a low light, because we like to have balance.
Yeah, okay. Gosh, highlights. I think part of this, what I've been doing for the last 2 years, is in many ways a highlight of what I've been able to deliver in my career so far. Because as a registrar, you feel like, it's a lot of service and it's a lot of delivery, whereas this has been a project where I've been able to improve service and been able to have a positive impact on the patient care we deliver, and hopefully, and it's ongoing, generate some interesting research out of it. So I think when you have personal responsibility for something, it becomes far more rewarding. You get far more invested in it. So this feels like it's what I've been doing, and it feels like it's my thing. And I'm really, we haven't finished it yet, but I'm really proud of what we've achieved so far. So that's a highlight for me. I mean, low lights, many different things, from different experiences in the middle of the night, feeling exhausted with very unwell people, or whatever it may be. And I've spent a lot of time doing general internal medicine, because that's what you have to do in the middle of the night in hospitals with 40 patients waiting to be seen and 3 of you to see them, and just tearing your hair out. And that will always be a part of the process, because some people have to do that work, but the patients aren't going away. So there have been times of absolute stress and absolute sleep deprivation, but the kind of long-term outcome and where you end up and where it takes you is very much worth the struggle. You can ask me that again when I've gone back into training, and I've been doing this for 6 months. But I certainly, having been doing this for the last couple of years, I don't regret my choices at all.
That's great to hear, thank you. And just to finish off, this is just what I ask, what 3 pieces of advice would you give to any, as I said, younger students or trainees who are wanting to either go into medicine or decide their specialities?
So I think
general or medical advice?
I think going into medicine, it's going into it with your eyes open, so knowing that it is very much a vocation, and there are lots of different things you can do within it, but the initial work is similar, and you have to want it for the right reasons. If you're going into this purely for financial reasons, it's not necessarily what it used to be in that regard, and the work remains fantastic, but you have to be interested in people, in helping them, and interested in kind of work that's associated with medicine. So that as a first thing, go into it for the right reasons. And then in terms of people going through training and making decisions, don't feel rushed. Don't allow people to make you feel like you have to decide right away and commit yourself to one thing or another. Take your time, whether that's in this country or another country, or whether that's through in-program stuff and out-of-program. Don't feel like there's an immediate need to make a decision. And there are some specialties where you have to show early interest, but actually you can take your time, you can build your portfolio, you can work out what I want to do, how I want to target my career. So don't feel pressured. And then when you do make a specialty decision, try and have some a look forward to where do I want to end up, how do I want to tailor these experiences for where I want to be, and how can I achieve that. So it's a combination of not feeling pressured at all, because you've got a long time to be a consultant, but also recognising that a forward plan at some point will help. So once it's 2 contradictory statements in some ways, isn't it? But I think it's recognising that you don't have to choose right away, but once you have chosen, try and have a picture of where you want that process to take you. So it's perhaps helpful in some ways and helpful in others, but it comes.
It's a spectrum, isn't it?
Well, it comes back to the fact that you want to make sure the choices you've made are the right ones, and then once you've made that choice, you want to be able to get the most out of it, essentially. So that's how I would kind of sum that.
Did we get a third one? So we said.
Yeah. Okay. Yeah, I think so. Once you've chosen, the risk of burnout, I think, from my perspective, is higher if all you're doing is the same stuff, and if all that same stuff is clinical medicine, particularly with on-call work and busy inpatient work, it can drag you down, particularly in some of the NHS structures as they are at the moment. You don't feel quite as supported as perhaps you might like, so you need something else. So diversify, whatever that might be, whether that's education, which actually is a very enjoyable thing as well, so whether it's education, whether it's research, whether it's additional skills that you develop, whether it's leadership, or whatever it might be, you need to diversify what you're doing so that it's not pure clinical, because that is, in the many years of your career, those are in my own experiences so far, those are the people that I see with less love for their work, other people that are purely doing that without anything else to say, right, this is what I'm developing, this is what I do, you know.
Yes, I understand. Thank you very much.
My
If
pleasure.
you have any final words for any junior doctors or trainees?
Yeah, I'd just say, you know, it is still a good job. It remains a very good job. It remains extremely rewarding. But just go into it with your eyes open and try and maximise what it can bring for you. Because there's a significant outlay associated with doing the work now as well, and getting to the point of being a doctor. So, go in with your eyes open, but also try and look after your own interests and how you're going to move your career moving forwards.
Thank you. That's brilliant. Thank you so much.
Thank you very much.
Thank you.